If you enjoy this content, please take a moment to rate and review it. Your feedback will greatly impact our ability to reach more people. Thank you. All right, we are thrilled to welcome back our friend TK, Tarun Kapoor from Virtua Health. Tarun, how are you, brother?
How are you, Vic? Marcus, glad to see you both. I know you've been getting a couple of vacations in every once in a while, well deserved. But I was telling him as we were chatting before, your podcast is prodigious. I have trouble keeping up because there's so much going on, but you do such a great job of keeping me apprised of what's going on. So thank you, and thank you for the opportunity to come back.
We love having you back. Yeah. Vic has taken some good notes on the show, so I'm going to let him lead, and I'll chime in with color. But let's jump in. We have a ton to talk about.
Yeah. Well, you're one of our returning guests, and so really our expert in the intersection of health systems in the clinic. Actually, how can we use these tools, AI tools, to benefit patients, benefit our clinicians? We talked previously about Virtua Health and its partnership with Wobot. So maybe let's start off with give us an update on how Virtua is doing and how your experience with the Wobot partnership is going, and then I'm sure we'll expand into lots of other things around AI.
So overall, Virtua, probably just like every other health system, what summer lull? No such thing anymore. It's just busy all the time. And I think we did talk about last time that this is a preview of the next 10 years. At least from an acute care perspective, there's just going to be a lot of acute care that's going to get just a lot of illness to have to work on and care for. And now that we have even more sophisticated treatments than ever before, there's going to be no lack of work for at least the next 10 plus years. And the question now is how we're going to be able to provide services. And I not only just an acute care perspective, but and Marcus, and I connected with you offline about some of the experiences you shared from a personal perspective, and I wanted to say thank you because there is an absolute human connection here and an awakening that we're all going through together. And so we're going to have to figure out how to use these tools because it's not going to be easy to deliver in a legacy way. There's just not an option. So we're going to have to do this differently. So things are busy here at Virtua.
Before we dive into that, I want to kind of double click on what you meant by the volume and acuity. At first, I thought it was a pent up demand after the pandemic, and it seems like it's more steady state now. So we're going to have this higher volume and higher acuity. Is that your view for the next several years?
Yes, and if you look at the demographics experts out there, they're going to tell you, we told you so. You can't escape the numbers on this one. So the current projections, based off of the curves, are only the first half of the baby boomers have aged into the 65 plus range. Only the first half. So you got the second half yet to come in. The moment you hit 65 and on, your utilization of healthcare goes up typically around 300%. And now you're going to be covering that, also backfilling that with a relative 17% decrease in working staff. So the mismatch is not going to go anywhere for another 10 to 15 years. And then as your good friend Kaveh Safavi, who has educated me on all of this, and then the problem resolves itself from a global perspective for reasons that probably not we're talking about in public, but you can read between the lines. And so therefore, if we're just going to say, well, we're just going to train up a bunch of people today, or we start the pipeline today, let's say from a physician perspective, you put someone in the med school today, bare minimum, 7 years before they're able to do anything in an independent fashion. And now could actually create some other problem of like a bunch of people we just trained up and there isn't the same amount of work for them.
Yeah, that volume, that big bolus of population need, if it takes 8 years, 7, 8, 10 years to train someone, they almost miss most of it. And then they come out as we are starting to have the decline. That's what you're saying, right? Yeah. So like there's lots of fear around AI replacing jobs in the overall economy. In healthcare, it's really interesting. We need the help. I mean, we're not going to lose people won't lose jobs if they want to keep working and engaging. We have plenty of work to do. We need to help these people do more, be more effective, deliver better care. And I think your partnership with Wobot was really one of the early partnerships exploring that. How can that work in behavioral health?
Yes, and we've learned a ton so far. And interestingly, since we last spoke, Wobot even got a place on 60 Minutes. And there was a feature on 60 Minutes about Wobot. Virtua got a clip. So we had 30 seconds of fame. And it's always good news when you're on 60 Minutes. It's not because you did something bad.
That's all right. That's all right.
Now I didn't make it onto the video clips. So as a kid growing up with Indian parents, that was a major disappointment because that is the epitome of being an Indian immigrant kid in the United States, is making it onto 60 Minutes for something good. But Virtua made it and Wobot did it, and I think I give a lot of credit to the way the 60 Minutes folks did it. They did a really nice job of explaining the difference between open and closed models and the pros and the cons of them. So as we talked about on the last time I was here, we started using Wobot late last 2023, which is a closed model assistant tool, not a large open model, large language model. We started to offer it to patients who had mild to moderate depression and or anxiety. And the idea of our hypothesis was, if we could partner with a digital therapeutic company and do it in partnership with them and then prove results, then can we go get a reimbursement code versus and put some money, put our money where our mouth where our money is, or money where our mouth is, how the saying goes, and show the results. And we actually have some results that we're now getting ready to release, and I'm actually glad to preview some of them here with you all.
Let's go.
Great. Excellent. I like that.
All right. So reasonably hot off the press. Again, I thought, we would be at 500 active users, and maybe I'll get there eventually, but we're not quite there yet. But we learned a couple things along the way. One of the things we learned along the way is we're not as good as we should be at collecting mental health data in healthcare. And if you think about it, there's just so much going on in a clinical visit that I thought, well, okay, first thing we'll do is we'll pull all of our PHQ scores, the PHQ Personal Health Questionnaire score, which is a depression score, and then the GAD score, GAD stands for General Anxiety Disorder. So if you hear me say PHQ is depression scale, GAD is anxiety scale. We didn't do as good a job as I thought we were doing in pulling that. It's no fault of our doctor. There's just so much going on in a 15-minute visit. And the honest reality of it is, I don't think this is unique to Virtua. You start asking those questions, it starts to open a floodgate, and that 15-minute visit is no longer a 15-minute visit, and you're already behind. And so we got to figure out other ways of getting this information, because there's unfortunately a time incentive not to talk about it, and that's just the reality. Just being candid, it's just the reality of the world.
Do you think another aspect is that prior to this partnership with Wobot, the doctor would collect that information, but there wasn't really a place to refer a patient to that didn't have a long wait list. And so, it's going to take a long time to lock them off my schedule. And then I find out that Vic has mild to moderate depression, but I can't help. And maybe it's better not to even open that up. Is that fair? Or maybe I'm reading?
No, I think that's absolutely fair. And I also think if you're in a clinician's office, talk therapy is the basis of starting treatment. Talk therapy doesn't happen in the last 5 minutes of a 15-minute encounter. All right, talk therapy is extended. And so sometimes the quote easy button is to write the script. That you can do. You can, e-prescribe something in 30 seconds. But the mainstay of treatment for mild to moderate depression, you can be assisted by medications, but the healing happens with the cognitive behavioral therapy. And that's what we've learned. So what we've seen so far of, first about 200 users have used it, generating about 1,400 sessions, 10,000 minutes of usage. We have seen for those who have completed the course so far, which is typically, at least 60 days plus. For the PHQ, which is the depression scale, we've seen about a 2-point drop in their depression score, which meets clinical significance. And the peak score for the statistical, my fellow statistical geeks out there, is 0.003. So it's statistically significant, legit significance there. And then for the GAD, also not quite a 2-point drop, just a little bit less than a 2-point drop, but also significant both clinically and statistically. And a couple other things that we've seen here, the usage is really interesting. 76% of the usage has been outside of our clinic hours. Vast majority of it happening between 6 p.m. and midnight, but we have utilization 2 a.m., 3 a.m., 4 a.m. So that was our hypothesis going in. One of the things that was not in our hypothesis, the amount of usage before 6 a.m. and 8 a.m. as people were waking up and getting ready to go to work. I didn't think that was going to be the case. I knew you may have trouble falling asleep, but to think that you're waking up and your utilization pre-work is almost the same as during working hours from a percentage in those dawn hours was really interesting to me. But I think what we're finding is that the tool can have an impact. Talking can have an impact. And I think that's what we're finding so exciting about this.
So first of all, that's fantastic feedback that you're getting, that you're statistically moving the needle. A couple just like brass tacks questions. As someone who does therapy, I never do the PHQ-9 in session. I always do it on an app outside. For the reason that you mentioned, just because like there's not enough time, we got to get to the talking right in our actual session. But the GAD, I'm not sure I've ever taken that. Can you just talk about what, like, literally, like, what are the questions in the GAD? Because I'm just not familiar with that one. I think most people know the PHQ, but what's actually in the GAD?
It's exactly around the questions that you're mentioning, Marcus, around questions around like I feel stressed, or I'm starting to anticipate. I have anticipatory stress about starting something. And
okay.
And how frequently do you get that? And then what is the impact? And does it start to impact whether or not you actually participate in something? Almost from a social anxiety perspective, I can right. I can pull up the specific questions easily, or anyone can, but that's what it is. And we know that depression and anxiety are very closely linked, especially anxiety can cause depression.
Right. Right.
And in that linkage. So the interconnectivity of these things just don't bucket easily. And say, well, I need one thing for this and one thing for that. These things interconnect.
Okay, that was great. And then just on the note of you realizing you don't do a great job of collecting this data, but now rolling out this pilot with Wobot, does Wobot fill that gap for you? Like are as you're recognizing this deficiency, and of course we're talking about constraints of workforce. A big part of this is how do we optimize the workforce and triage, the most severe cases of depression, anxiety, and other related mental illnesses, to the people who need to be spending a lot of time with people, and how do we use technology for the rest? I mean, is this Wobot app going to be part of your improvement in clinical data collection?
To us, this is a very important, what we call PRO, patient-reported outcome. And it's only going to become more and more actually mandated. Just in July 1st, for CMS mandated that if you're doing joint replacements, you have to collect perioperative or preoperative patient-reported outcomes, and then you're also going to have to collect at the 12-month mark how to do that. So this is going to become the standard of incorporating patient-reported data into your plan. And if you're only saying, well, the only time I'm going to ask is when they're physically in front of me, we're going to be held accountable for a completely different way of doing this, which in a value-based contracting world has been around for a long time. Now in even a fee-for-service environment, it's starting to converge, I would say. So yes, and we're just going to have, I think you're going to have to give people more flexibility to share their outcomes in mechanisms outside of their patient portal as well.
Right.
Patient portal is great, but if I can widen the funnel by using another tool, I need to get the data in.
I mean, it's really impressive results, and maybe as importantly, you're helping 200 real people in your treatment area get better and feel better and have more productive lives. So that's all really impressive and incredible. I'm interested for you to compare, if you can, these results compared to the traditional in-person talk therapy, CBT therapy. Is it a similar size and scope? Is it hard to compare? Is that not even the right question? How do you think about this protocol versus the more traditional protocol?
I'm not sure if we're ready to compare it to traditional, because it's, again, we're really still pushing very hard on adjunctive. This is meant to be supplementary to this. These are folks who we're still encouraging to go see a licensed professional, a psychological professional. Where I do think, and where we have to do some additional sub-analysis, and this is where the data gets hard, is, well, what if he didn't go? Did he still get better? Because a lot of people we may recommend to go, and they don't go either because there's a stigma is usually the biggest one. But let's be realistic. Cost is not insignificant for psychological therapy. Many of folks who provide it are out of pocket these days. And then if you even do have somebody getting in. So where we have to do the greater analysis, and this is where I think partnering with insurance companies, because that's the nice exciting piece, is, well, they'll know if they're reimbursing for it. I don't know, unless they only stay within my network, but we may not have all the providers. So I think that's the next place of presenting the data back to say, is your total cost of care going down on these patients? Because if it is, now we lined up beautifully.
Yeah. Okay. I think that's fair. And I think an adjunct therapy is what we need. I was trying to lead to kind of making the case that this should be reimbursed by someone. And the frame of reference I have for that is the existing therapies, that whether they're self-pay or reimbursed, that there's a structure there.
What I'm especially excited about for this, and maybe this is where I'm negotiating myself or negotiating against anyone who's in the digital therapeutic space, what I think is actually exciting about a digital therapeutic compared to a traditional pharmacologic therapeutic is that the quote payer has to pay for let's say a pharmacologic therapy. Once the medicine is dispensed, they have to pay for it, regardless of whether the patient takes it or not.
Right.
We could actually build out a model here to say, I can dispense this thing because I'm just giving you an access code, but reimburse me when they use it.
Right.
And so could this potentially be, without having to go full-blown capitation, can you use this as a fee for almost as hybrid of a fee-for-service model if you're in a fee-for-service environment that then says, well, but only pay me if they're using it. And if they're not using it, stop it. And if they stop using it, stop. That if we can pull that off, that I think becomes the best of all worlds here, because now you're paying for effective therapy, not just dispensing a pill that's sitting in someone's medicine cabinet.
Yeah. Okay. I think that makes sense. And then the kind of the other side is, there's a safety, and with behavioral health, there's a safety or triage concern that I know Virtua was interested in, Woebot I think is interested in. Did you see any signs of that, and could you get people help when they needed to be kind of escalated? Or maybe 200 wasn't enough, but that's a really important piece to follow. At least I think it's an important piece to follow.
Oh, great question, and absolutely is one of the biggest issues that we had in our heads before we got started on it. And so the good news is, very, very good news, is that we have not seen anyone trigger language that required immediate level of attention. But the system, from our testing, the system is able to pick up concerning language. So it continues to be able to produce that. And for those who are still a little bit hesitant, what I would ask is, okay, well, if a patient calls and leaves a voice message to talk to the clinician, and does your voicemail automatically detect concerning behavior?
Right.
Reality is medical advice messages through your portal. A lot of those don't get checked for 24 hours. At least this language model, this closed model is able to detect some of that language immediately. But so far, we're not seeing that.
Yeah, so you are looking for critical phrases or words around suicidal thoughts or something related to that. And we don't need to give any exact words, but it's screening for that. And it's great news that the small number you didn't see any of those, but that security measure, that safety measure is in place to the best it can be in place with Woebot.
It is there. And we feel very comfortable about that. I mean, the other thing is that we've also been selective in who we've offered this to. We've focused on mild and moderate depression.
Right.
If a clinician, when they're recommending this product, detects severe depression with some concerns of self-harm thoughts, we are staying away from it. Now, that stated, you can make an argument, well, then what are you still offering? If you don't have anything, could anything be beneficial to nothing? I don't know how to answer that one at this point. But yes, we have decided to stay away from that for now. But I think it's a valid conversation given the simple fact that there's such limited resources out there.
Yeah, it's an unfair comparison. And I wanted to ask it because I think a lot of listeners will be saying it to themselves. My belief is that getting people some help and help at different parts of the day, at 9 at night or at 5 in the morning or whenever they need it, is clearly, in my mind, a net positive. And yet I think AI tools and support tools are held to a ridiculously high standard that traditional services are not held to. As you say, that if someone calls in and they leave a voice message, that's not checked for a little while. But I wanted to ask it just because I think a lot of people will end up digging into it. So,
well, there's a lot of places we can go with this conversation, and maybe I'll hold this comment for later. But I agree with you. There's this thought. I think it's a false promise that, well, it needs to be 100% accurate or 99.5% accurate before we'll adopt it in healthcare. It needs to be safe. Safe and accurate are two different things. And we're very comfortable that this digital therapy we're using is safe. Is it 100% accurate? No. But the other question, and one of our board members questioned me on this, is, well, what is good enough in terms of correct? And the question I posed back, well, do you know what the passing exam score is for the United States board exam? And the answer is you need to get about 70% correct in order to become a board licensed physician. So I think the number probably should be higher than 70, but we don't hold our doctors to 99.9% correct. So how much are we going to be withholding from people because we're waiting for perfection? But safety and perfection are two different things, and I think they can be separated.
Yeah. So that's why I wanted to talk through the results. You had a measurable and statistically valid impact on patient outcomes that you haven't published it yet, but you're worldwide breaking news right now. And also, you have these safety measures in place. Thank goodness they weren't triggered, but they're in place, and if needed, they're in place.
And it's not if they're going to get triggered. At some point, they're going to get triggered.
Yeah.
It's not if, it's when. And we will continue to watch that very closely.
Anything else you want to talk through with Wobot?
No, that was a fantastic update. Great.
Yeah, I'm super excited. I mean, you really were a leader in sort of bringing this out in the best, well-organized way possible, but still, there's no certainty, and it's really exciting to see it having some early success. So.
Yeah, well, we're not over the finish line yet. We have to take it to the next level and go ahead and get those codes. So we mentioned we had a high-level agreement with somebody. If we could show good numbers, then so we're ready to present the numbers back. We're talking a little bit about them here. And we do have actually a second insurer who has also expressed interest in this as well, because everyone's come to the same conclusion. We know that mental health has a very significant impact on total cost of care. We got to do something. And we think this is a good solution. It's not the only solution that needs to be in the toolbox, but it's something that we strongly believe in.
Yeah, excellent. Well, and I want to broaden now to talk about the overall AI market and LLMs. Do you have a minute just to sort of talk through what you're seeing in the overall market? You're sort of one of our AI experts that are coming in to help us understand the overall space a little bit.
When the previous session that you put out, the title was AI Pioneer. I am not an AI pioneer, but I'll take expert for today. So I'll try to give some insight as to what I understand. I'll tell you what, I mean, they talk about exponential growth being hard to keep up with. It is hard to keep up. I am spending a ton of my time just trying to understand this stuff, and I get to do this all day. It's wild, but very exciting. But yeah, let's unpack it.
Yeah. So I want to now talk about the large language models, and I mean they are growing and changing and evolving quickly, and we're starting to see some healthcare focused LLMs. And what are you seeing out there? How do you evaluate these models? What should the listener look into that really would be applicable in medicine or in healthcare or in payer markets?
Way I'm trying to think through some of the large language model use cases in healthcare is well, and again, I think we started a little bit about this open versus closed model. So first question, to unpack that a second, the closed model is you define all the parameters of responses, and even though it can listen broadly, it will answer narrowly. And my initial mindset was, well, I want you to answer narrowly. The downside of that is you start to lose engagement of the patient. If it sounds like the response is always the same thing in a very contained, it's controlled, but you may not get engagement. And I'll tell a story of, I tried to play golf and I was taking a lesson and I was slicing the ball and kept on doing it no matter what the instructor said. And then by the sixth time, it started to straighten out. And I said, I'm curious, what would you told me to do if I kept, this didn't work? He says, I don't know. I only have 6 ways of saying the same thing. But a lot of times in healthcare, you have to adapt your language to say, you know what, this is what I'm saying is not registering with you. So let me try this angle. Let me try that angle. But the principles are the same. It's not that the principles are new. I'm just trying to convince you as a health coach, and a lot of medicine is being a health coach, how to adopt and change how you do these things. Closed systems are going to eventually struggle with that. So everyone who has a closed system recognizes the LLM is coming. The question that people need to be asking themselves is the LLM going to have open data or pulling data from a quote public source? Or is it only going to read from a very narrow source? And if it's an LLM that reads from a very narrow source, we don't really know how that's going to play out because these things consume enormous data sets.
Right. So
there's this conundrum that's to be determined. but a question I think people should be asking themselves as they're vetting this is, so what are you reading from? What is feeding your model? And if they can't tell you what is feeding your model, or you need to be comfortable with what's feeding their model. And in order to get some of these better, more empathetic responses, they're going to have to read from other sources. I do feel better about the hallucinations.
Say more about that. Why do you feel better? Are you seeing the hallucination rate come down significantly? Are you seeing guardrails being put in place that, what's the real progress happening there? Because this is the first time I've heard anybody say they feel better about it.
I didn't say I feel good yet. I just feel better.
No, better.
Yeah, the reason I'm starting to feel better about the hallucinations is an understanding, and again, I'm probably outside of my depth on this one, is what we call temperature in LLM models. So ChatGPT is generally a warm model, which allows it to have a lot of creativity. And you want to have creativity, right? Because it can make a rap, it can make a iambic pentameter sonnet. But in healthcare, we don't want it to be too warm. We want, like, if you don't know, say you don't know. Now that we're able to start getting some of these more healthcare focused models, they're tuning them accordingly to healthcare. And that's where I'm starting to feel a little bit more comfortable. If you still ask, you can probably trick GPT-4o to hallucinate because it's a warm model. But for some of these healthcare specific ones that we're starting to toy around with, that's actually pretty decent responses. What excites me about them is because we've been predominantly using closed models, very programmatic machine learning or knowledge graphs, but the speed to adoption to these, the speed to programming these things is so much faster now. Before, it would take us a year, or 6 months to a year, to really kind of tease out a knowledge graph model. Now I'm coming back and I'm playing with this thing within a couple hours of it. Again, there's a big difference between playing with something and feeling comfortable from a safety perspective. But I do feel that there's a lot more conversation happening out there about safety platforms, whether it be so the work that's being done by Justin Norton and the qualified AI team. Hippocratic AI has put out a safety portal where you can test out what it's doing there, and this is starting to expand. So the healthcare LLM is starting to make some progress here.
Yeah, and on that temperature lever, I was trying to start up. I didn't end up investing in it, but they were trying to bifurcate the social, cultural, small talk aspect of the LLM, for lack of a better word, and then make that very warm, creative, empathetic, but then kind of lock down the clinical pathway recommendation piece so it wouldn't be creative or open, much more science, evidence-based. I don't know that they have figured that out, but we're starting to get more and more use cases or more nuance around it, which is kind of interesting, I think.
Yes, but the fact that we're even having this conversation, that you're able to potentially bifurcate a model now, that some parts of the conversation are warm and some parts are quote cold and more just exacting. I mean, sure, like that's what we would want in the ideal doctor, like someone who is a just remarkable technician and just focused for when they're in the OR, and then someone who's Trapper John MD when they're at the bedside. I'm sorry, I just completely dated myself.
Yeah.
Right.
Yeah.
But that's kind of what's exciting about this, is that we can create multiple aspects to this based off of short and concise and sweet to the point when you're in the OR, because that's bam, bam, bam. Time is life, and gregarious and outgoing at the bedside when you need to be talking to somebody in a very warm, engaging manner. This is exciting.
Yeah, and so the pace of change I wasn't that confident that they were going to execute it, but the pace of change is really, really exciting. As you said to me, it's hard to keep up with, but there's a lot of change, and this nuance. I mean, we're no longer satisfied with, okay, it can write a sonnet in 4 languages, but okay, what can we do that could be more applicable?
I saw a meme somewhere, which I think does summarize some of the frustration. We're going to probably, from a Gartner perspective, start getting into our trough of disillusionment soon. But I want AI to do my laundry and dishes, so I can do art and writing, not the other way around.
Right.
Yes.
Yeah, because
Yeah.
and I think that's what happened. I mean, people may have seen the Gemini ad that was playing during the Olympics about show my daughter how to write a letter to my daughter to her track star idol.
Yes.
And they pulled it because wait, that's not what we want AI to be doing.
No.
So I do think that was interesting.
So it feels to me like next year this time, we could be, as we have you back on, we could be having a conversation that has nothing to do with the technical ability of the LLMs. We let's just assume in a year we're there, and it's much more about the regulatory environment and society's willingness to adopt. What are you feeling or seeing there? I mean, part of your job as a chief digital transformation officer is to track all the tech and run these pilots, but part of it is to be able to communicate and translate and also track the regulatory environment and how ready the rest of the world is for where the technology is. Where are you seeing things? I mean, obviously the LLMs are moving at a breakneck pace, and there's been so much capital, whether we're talking about the Magnificent Seven or venture capital, so much capital's been pushed into this space over the course of the last year. What are you seeing outside of that? What are you seeing in the government? What are you seeing in just your coworkers' willingness to sort of accept the fact that this tech is really starting to get to the place where it can be truly helpful to them?
I think that is the question that I am trying to spend the most of my time on trying to help my organization understand what is the impact. I remember when GPT 3.5 came out and I did a presentation to the board, I put a slide together, and one of the slides was 1/99. Everyone's going to focus on the 1%. Do I have enough data scientists to build out my tech stack and all of that? And I think where the opportunity is like which organizations can figure out how to get their 99% of their workforce who's not deep in the tech stack to understand and adopt this. And I think the hypothesis is completely borne out. There's still a lot of excitement and hype around the 1%. Most organizations, whether you're a healthcare delivery organization, anywhere in this space, you need to be thinking hard about the 99, is what I tell folks. I think we are going to have some really interesting challenges around identity in healthcare. And what I mean by that is there are tasks that these tools are starting to be able to do. But these tasks fall into historical identities within healthcare roles that are core to the identity of that healthcare role. So let's say we talked about Wobot. Having a conversation in an empathetic fashion has been core to caregiving for a long time. We're not taking that away from the clinician, but there's another participant in the conversation now. And so there is going to be, I think, increasing concern from, well, what does this affect my identity? I think a lesson learned for us here, and it may be too late. It may be a situation where it's the equivalent of Kleenex is Kleenex and not tissue paper and Xerox, et cetera. Virtual nurse, I think, may have been one of the worst terms we could have come up with. Because there is nothing virtual about our nurses who are interacting with these patients. They are real live human nurses. They just happen to be using remoting technology so they can come into the rooms. But guess what? There are actually some virtual nursing tools now. that are truly LLM AI. And by the way, we talked, I know if you saw the video clips when for NVIDIA, when they had, they talked about Hippocratic AI, and they had the virtual nurse with the avatar, and they got a lot of flack for that. Interestingly enough, rumor is that wasn't Hippocratic AI's idea. That was NVIDIA's made the video for that. So because NVIDIA thought it was cool.
Right. They don't know healthcare.
Yeah, but then the healthcare side is like, dude, that's creepy.
Right.
But what's really great about some of those tools, the voice interaction is great. It really seems pretty solid. So now though, we're going to have this butt up of, wait, am I a virtual nurse? Or is that a virtual nurse? Or am I actually a nurse who's using technology to remote in such that I can, be more accessible because I can be in multiple hospitals and covering multiple hospitals. Same thing with our clinicians. And I think, we talked previously before, we're betting big on this. We're wiring our entire health system, every med surge room our goal is by first quarter of 2025, we'll have, we're on the Carry AI platform and big news on that one too. But we're betting big on the smart hospital because we recognize what a limited resource our clinicians, our physicians, our nurses, et cetera, are. We're going to give them every tool possible to spread their presence into patients' rooms. Ideally, we want to be in the patient room too, but at least we're going to enable them to, if I don't have to have a cardiothoracic surgeon driving between hospitals and you're in the OR and does a video visit with you when you have an abnormal catheterization, and then we'll meet you at the hospital, you've already met your surgeon in advance, that's a big win for us. So, but now we're starting to get into identity questions, and I don't have the answer to this. This is what I'm working on and thinking about. It's going to get interesting.
Yeah, and I agree. It's the question. It's also a marketing, branding, ego question, not really a technical question, right? So, in my own mind, I'm a great driver. I could have been an Indy driver, but I decided I wanted to hang out with Marcus and do venture. But I still have anti-lock brakes in my car, and there's no way that I'm going to be able to pump the brakes at that pace per second on a wet road. And even like the most egocentric person like me that thinks I'm a good driver, you still want anti-lock brakes, right? And so that we got to figure out how we can say to the physician, the nurse, the administrator, these are tools that are going to empower you to do the things you really do well. And then there are things like anti-lock brakes that just a computer can pump the brakes, whatever it is, 4,000 times a second. And even though I am in my own mind a good driver, I can't do that, right? So it's not like diminishing to me to use these tools. We have to figure out how do we position it like that so that our great clinicians want to use it.
And I think then the question comes back to, well, and using the race car driver analogy, is the feeling, well, my identity as a race car driver is being able to drive the most raw form of automotive technology without assistance. And I think you could potentially look at Formula One now. Well, we still think those are the greatest drivers in the world, right? They not even drivers, they're pilots at this, what they call them.
Yeah.
And they're able to manage that technology in the cockpit at any given time. And yes, they still need to know the lines, but those drivers of today versus the original drivers, the Juan Manuel Fangios, et cetera, different drivers. And it's okay.
Yeah.
But
yeah.
And in some ways better. I mean, they're definitely different, but they are very proud of the skills that they have today. They're very tech enabled, but it doesn't diminish them in any way.
I mean, you could just look at the steering wheel. It is
Right.
two radically different steering wheels, right?
Right.
the number of buttons on that, they're having live conversations with their pit while they're driving 200 miles an hour, around a turn. I mean, that is a different skill set, but they still identify themselves as race car drivers. And I think that's the challenge that we're going to have in front of our clinicians to say, you're still a clinician, even though you're not the purist with the goggles in the race car anymore. You're going to be monitoring all of these other systems while you're still steering the patient's health to an outcome. If you want to say, well, I want to drive old school way, then there's a place for you, but that may not be in the modern healthcare system. And I think we can help get our folks there.
Yeah.
TK, I actually just texted Bruce Brandis. I told him we're talking to you. It's time to get him on the show.
Yeah.
But as a preamble to that, help Vic and I understand. We were talking before we hit record. Help us understand the significance of the Stryker acquisition of Care AI.
So full disclosure, I'm biased here. We've been working with Care AI. As I mentioned, we've committed to wiring all of our med surge and ICU beds with Care AI sensors. We're about 300 or so in, but hope to be done by first quarter of next year. The argument behind this is, to me, a big swing at the concept of the smart room. And this is not a virtual nursing play. This is are you a believer in the smart room, the smart hospital room, of which virtual nursing, which again, I think that's a debatable term, is a component of it. But if you look at virtual nursing for the most part actually doesn't remove nursing. It actually adds, and we've made as an organization, we're not opposed to that because it's bringing the right type of care to the bedside, human to human, of course, with a telemediation in between. Where you get the wins to pay for this is all the other ancillary technology or redundant technology that you don't need in the room at the same time. So today, if someone needs to be monitored for telesitting, you roll in a separate cart and camera for that. Now you don't have to do that now. I think the synergies between Stryker and Care AI now is, well, Stryker makes beds. Care AI has a sensor. Now Care AI can look at it and say, you know what, that patient is starting to move a little abnormally, or they're starting to move, thrashing around a little bit. Let's turn on the camera and see what's going on with them. Their ventilator, it's time to wean them off the ventilator. Let's look and make sure that the bed is at the right angle. So there's a bunch of synergies that start to come in here to make the room smarter. And I think it's a pretty smart move for Stryker to swing big on this. And now you give Care AI a bunch of funding on these ambient use cases. Very, very, very interesting time ahead.
Yeah, and what I want you just to spend a minute on is kind of play out the strategic roadmap. I mean, the combination is really interesting in that AI intelligence layer with Stryker's physical hard products is a pretty powerful combination out there, and I haven't seen that combination put together anywhere else. I mean, there are other makers of beds and devices and the infrastructure, or tables and everything, but I don't know that any of them have an AI layer. Is that kind of your view, or who else do you think's in this space that's gonna want to buy some of Marcus and my portfolio? That is already trying to catch up.
So from an AI, let's say ambient sensing, the way I've been thinking about it is that from a sensing or an AI layer, you can either watch optically and visually, or you can watch ambiently with using LiDAR technologies or infrared, et cetera. The legacy players in this space watch with camera bandwidth. The problem is you can't watch 1,000 rooms in a health system or a medium-sized health room system. You can't watch with 1,000 cameras at high definition. You'll destroy your bandwidth, right? There's not an option to do that. Yeah. So you got to be able to watch ambiently with shapes and computer vision, which is and the other piece is you got to be able to do it at the edge, where the inference computing is happening at the edge, not all at the central point of it.
Right.
But now you're really starting to get into the concept of these micro Internet of Things, and so the Internet of Things is what's the IoT inside the room, and you need to start getting into a critical mass of devices that are actually able to feed off of each other. Because if, let's say, the Care AI platform detects abnormal movement, now the Stryker bed could say, "Yep, I'm seeing it as well," or "Nope, that's not abnormal movement because that is a family member who just put their bag on the person's lap, and that's not abnormal movement because the bed is able to detect the difference." So as we're able to understand more and more, believe it or not, one of the hardest things for us to figure out in healthcare is how much weight a person has lost or gained during a hospitalization. Well, if I have multiple sensors now telling me, I think the weight is this, then I can adapt my treatment protocols. Because if you get admitted for heart failure, my goal for heart failure is for you to lose X percentage of your body mass, which is excess weight, in X number of days. And if I'm not doing that fast enough, I'm not doing my job. Problem is weighing patients is a real pain, right? And very inaccurate. But if we can start figuring out other ways, volumetrically, what is your weight? What does body mass stretching look like? What does impedance look like? Now we have a very different way of managing people. So I think the smart room is only going to get smarter.
And do those sensors have to flow through the EHR, or can they be separate? Well, I don't think you're relying on the EHR necessarily. Is that true? So they can get away from Epic Cerner bottlenecks at some level.
You are not reliant on all of it running through your EHR. Absolutely. The EHR can feed it, and you can feed the EHR. But you can run these things completely standalone. And I think where they're recognizing there's an opportunity to compete in this, not even compete in the space, but I think augment in this space, is there's a lot of activity that can be captured in real time, both through ambient listening, but I actually even think now through the concept of ambient vision. There's a couple technologies we're using that will watch a procedure to, I think we mentioned there's augmented reality during a colonoscopy where it'll put a box around it if it thinks it's a polyp, which is right. And I would argue if you're going to have a colonoscopy, you better ask and make sure that your doctor is using one of these ambient technologies, because a clinician can miss it. But the other thing I would say is, why can't this thing generate your op report afterwards? It watched the procedure, and now it's able to do that. Well, you know what? That gets immediate adoption. So why not have that conversation, have the entire conversation with the patient in the room, and then by the time you walk out, they already forgot half, or they didn't ask the questions they wanted to. Now they can listen to a transcript of what just happened. If they're interested in that. If they say, I don't want that, that's a different story.
Yeah.
Right.
Or if they approve, a family member could be let in to see that as well, because they have a lot of questions. And it's not that the mom or the grandmother doesn't allow the family to have, but you can't get the doctor back and they don't recall all that.
I know we're probably bumping time, but the use case they had for us that completely sold us on this was family member got it admitted, elderly gentleman, wife was at the bedside trying to say, what's the medication list? And we don't have the medication list. Oh, but our son in this state has a medication list. Added him to the call on the fly. Okay, what's the medication list? Oh, you know what? My sister picked that, said she picked that up. Let me get her. Oh, no problem. Text. She's on the line. And now we had 4 people having a conversation around, the patient's information. We got real-time information, got him the information he needed. Try doing that in real life. How often do things get missed because you can't be there? So I think that's where this is the reality of the world we're going to have to be in.
Yeah. So we are coming up on time, but let's just spend 3 minutes on where you think the future of the workforce is headed. I mean, this is obviously, we've already talked about it, going to really impact how we kind of organize our human labor to treat patients with the most effectiveness and best outcomes for the lowest cost. I know you're really involved in thinking that through. How should the audience start to think about that, or give us just some pieces and parts that we can start putting in? We'll probably have to come back to this at another time, but how do we start beginning to think about the future of work in healthcare?
So, and again, I reference my friend Kaveh Safavi on this one, and I think some of the things I'm going to share, he's helped me think through this as well. Is we know already that AI to begin with doesn't replace jobs; it replaces tasks. But then, if you start to replace enough tasks, the work that's left behind is fundamentally altered, not replaced, altered. So now the question is, what is the type of person who can be way more flexible and do one thing today and a different thing tomorrow? And that is very different from the skills-based world that we think about today. The skill set that is going to be needed for the workforce of the future is going to be the critical thinker. And yes, we have lots of critical thinkers in healthcare, but almost at every level, we're going to need critical thinkers. I think that's what we're trying to figure out is how do we understand the skill set? It's very easy to know whether someone has XYZ skill set. There are verification programs to do that. But do folks have critical thinking skills? Because the machines will make mistakes. And so critical thinking will say, oh, that doesn't right, critical thinking. Or I could do this differently, critical thinking. So you have to be thinking through how am I going to, and I think you can teach critical thinking too. It's not an inherently, talent. But what are people doing to not just teach skills, but teach critical thinking skills? And that needs to be built into your workforce development plan at a very early stage. And I don't know how to do that yet, but I'm figuring that out.
Yeah, I mean, I kind of think about that as finishing skills or quality assurance skills, and most people are geared towards the first 80% of the work, not the last 20% of the work, and are actually pretty sloppy when it comes to the last 20% of the work, right? And so that's a fairly big shift, and I think there's an identity shift within that, right? Because I think most people are very anchored to their strengths and their values being in that first 80% of the work, and switching them to being finishers and quality assurance people. That's going to be interesting.
Yeah, and our existing workforce training systems from high school to college to professional schools are really focused on those skills-based largely. And then they sprinkle in a little bit of critical thinking or strategy work as a nice to have. Right. We need to maybe flip that. So, I mean, this has been a lot. I think that's a good place to leave. I mean, just even that concept of AI doesn't replace jobs, but it replaces tasks. And as you start to replace multiple tasks, the jobs that people need to fill is going to inherently change. That is really good. I need to think through the repercussions of that, but there's a lot there.
It's going to be an interesting few years.
Yeah, I mean, so in the last hour, we have this bolus of the boomers, which is just now coming into their 300% utilization peak. We've hit the midpoint, but that means there's half more coming. The tool we bought testing is going really well. You're going to publish the reports internally, but the summary is going really well, and you'll keep expanding it, I hope. And the LLMs, the more open systems, are starting to get much more powerful, and we're getting to have more levers to be able to sort of pull in the temperature in some areas and sort of maybe, I don't know if it's fine tuning or designing it for healthcare uses. Huge acquisition with Stryker and Care AI that you're an early adopter in, and you're rethinking the entire way our workforce changes. That's a lot to digest in an hour, and really thank you for talking us through it. There's going to be a lot of change in the next 8-10 years, and I'm pretty excited about it. I mean, there's a lot of there's some things to think through, but for the most part, it's going to be better for patient care, better for outcomes.
Agree.
I concur as well. So it's making sure we're having meaningful conversations along the way, and being very open and transparent with each other as to what we think it's going to look like, and just not giving false hope or promises, but also not sugarcoating it either. It's like, oh no, everything's going to be the same, because it's not.
So TKC in 6 months?
You tell me when. I don't know. We'll see how much I can produce in 6 months, but we'll go from there.
The last 6 months, you produced a heck of a lot. So I think I'm really excited to continue our conversations. If something breaks, let us know. But there's a lot. I really appreciate you on the inside of a big health system, being willing to, think about things on the edge and really try things in a safe way, but try to figure out what's next for our whole industry.
Appreciate that, and we'll maybe see you at the 3P.
Yeah.
There we go.
Yes.
All right. Thank you, buddy.
Take care, gents.